Good afternoon, everyone, and welcome to the AMCHP webinar, Understanding the New CDC Contraception Guidelines. I'm Michelle Eglovich, and I'm a Program Associate for Women's and Infant Health at AMCHP. And on behalf of AMCHP, we're happy that you're joining us today. This webinar is part of AMCHP's Women's Health Info Series, which is a webinar series supported by the CDC Division of Reproductive Health, designed to not only increase awareness of key clinical guidelines and evidence-based programs and policies that impact women's and infant health, but to give AMCHP members and partners special access to content experts. We're very fortunate to have Dr. Katherine Simmons joining us today to give us an overview on the new CDC contraception guidelines. But what's more is to engage with you in a discussion, to hear from you all, and through your participation, hopefully, point to potential additional resources or supports that AMCHP and the CDC can provide as you integrate these concepts into your everyday work. So before I get to the specifics about the agenda and turn it over to our speaker, I have a few housekeeping items. So at the beginning, all lines were muted at the start of the webinar because we have a big group and we want to minimize any background noise or hold music. If you have any questions for our speakers during the webinar, please enter them into the chat box that you can see in the lower right-hand corner of your screen. The AMCHP staff will monitor this box closely and either ask questions on your behalf during the Q&A portion of the webinar, or if you prefer, you can press *6 to unmute your line and ask your question at that time. You can also raise your hand or otherwise communicate with us. For example, you can tell us to slow down or speak up using one of the icons in the drop-down menu at the top of the screen. And if at any time you have any technical difficulties, you can chat me in the chat box or you can email me at meglovich@amchip.org. So above the chat box in the right center or the right upper hand corner of your screen, you will notice that there's a file share pod. And here you will find the speaker slides for today. Links to the resources that will be discussed in today's webinar are available in the slide deck. And I will also send out the links in the post-webinar email as well. So I do want to note that today's webinar will be recorded, and the recording will be available on the AMCHP website at www.amchip.org. and will be directly emailed to registrants following this webinar should you wish to share the content with your colleagues. And one final item, please take a moment at the end to complete the webinar evaluation. A link will be included on the last slide of today's webinar, which you can access immediately following the webinar, and the link will also be distributed with the materials following the webinar. So, with that being said, let's move on to the program. So we have a fantastic speaker to assist us in achieving the following learning objectives for today's webinar. Describe the need for the new CDC guidelines and their role in health system capacity to respond to reproductive health and family planning needs. Evaluate the feasibility of implementing the guidelines to ensure quality of reproductive health care within your jurisdiction. And create first or more advanced steps in a plan to integrate the new CDC contraceptive guidelines into family planning and contraceptive services efforts. So we have a wonderful speaker with us today, and it is my pleasure to introduce her. Dr. Katherine Simmons is a board-certified gynecologist with fellowship training in family planning. In her current position as a guest researcher at the CDC, she has been heavily involved with the development of the new clinical guidelines. She has also served on the Zika emergency response on the contraceptive access team, focused on increasing access to contraception in Puerto Rico and other parts of the U.S. Dr. Simmons is also an adjunct assistant professor of gynecology and obstetrics at Emory University, where she practices as a family planning specialist. So without further ado, I'd like to turn the floor over to my colleague, Andrea Cornell, for some opening remarks before Katherine gets started.
Great. Thanks so much, Michelle. My name is Andrea Cornell. I'm the Senior Program Manager for Women's Health at AMCHP. And before we dive into the contraception guidelines, I'd like to just take a few minutes to center us on how these guidelines fit into the landscape of Title V MCH services block grants and the ongoing efforts state MCH leaders and partners are implementing to enhance access to family planning and to improve health outcomes. The Title V block grant has a long history of ensuring access to family planning and reproductive health services. Together with complementary programs, Title V funding enables continuity of care, and MCH specifically focus on activities related to family planning based on the priority needs identified from their Title V needs assessment conducted for the previous annual report and application. These activities are spread across the block grant domains of women's and maternal health, perinatal and infant health, and adolescent health. In most cases, though, they relate mostly to two national performance measures in particular. National Performance Measure number 1, which is the percent of women with a past year preventive medical visit, and National Performance Measure number 10, percent of adolescents ages 12 to 17 with a preventive medical visit in the past year. I know for many of you in the audience, you know these very, very well. The inclusion of family planning and contraceptive services in block grant applications is consistent with what we're seeing from states, especially around activities for National Performance Measure number 1, where they are essentially deconstructing the well-woman visit to focus in on particular outcomes or behaviors of greatest importance, like screening for substance abuse, depression, or in this case, contraception. States are targeting women at different times in their lives as well, including preconception, pregnancy, and postpartum or interconception periods. In AMCHP's review of the block grant applications from last year, not those that were submitted just this past July, over 20 jurisdictions had objectives or strategies that directly related to family planning. We don't have time to walk through all that we've learned from our members through those last year's applications and this year, the most recent reports, but suffice it to say that the SMART objectives that states shared as a part of their state action plan tables are all tightly connected to the goals of the updated contraception guidelines. These objectives focus in on use of the most effective contraceptive methods, on specific outcomes like birth intervals or unintended pregnancy, or on the implementation of guidelines like the QFP guidelines to address priority needs from the Title V needs assessment. The strategies and evidence-based strategy measures that align with these objectives, which we can certainly go into more detail at a later time, they become even more diverse as states leverage and focus in on specific activities to advance these particular objectives. They focus in on specific populations, specific methods, and specific provider types or contexts. So what's perhaps the most pertinent for this webinar in particular is that the implementation of evidence-based guidelines, including clinical guidelines, is consistent with this reinvigorated commitment of the Title V MCH Services Block Grant to support evidence-based practice and interventions to move the needle in critical population health outcomes. We are very lucky to have Dr. Simmons walk us through these guidelines, and we're looking forward to the discussion that will follow on how to best support their implementation as you advance your own work moving forward the objectives that you've outlined in your block grant applications and reports. So with that in mind, I'll pass it back to Michelle to pass it back to Dr. Simmons.
Great. Thank you, Andrea. I will now turn it over to Dr. Katherine Simmons to bring us deeper into the new CDC guidelines and the context surrounding them. Dr. Simmons, the floor is yours.
Thank you so much, and good afternoon, everyone. My name is Katherine Simmons again, and I'm an OBGYN and family planning specialist within the Division of Reproductive Health at CDC. I'm happy to be presenting today on the 2016 updates to the U.S. Medical Eligibility Criteria and U.S. Selected Practice Recommendations for Contraceptive Use. These are both documents that provide clinical guidance on contraceptive safety and provision. During the presentation today, we'll review the U.S. Medical Eligibility Criteria for Contraceptive Use and the U.S. Selected Practice Recommendations for Contraceptive Use, which I'll also refer to as the MEC and SPR. We'll review the intended use and target audience for these guidelines, and also strategies that clinics and hospitals can use to help clinicians incorporate the CDC contraceptive guidelines into everyday practice with the goal of improving the overall quality of family planning care. The U.S. Medical Eligibility Criteria, or MEC, is an evidence-based source of clinical guidance for the safe use of contraceptive methods by women and men with various characteristics or medical conditions. It's intended to assist healthcare providers when they counsel women, men, and couples about contraceptive method choice. The U.S. MEC includes over 1,800 recommendations for more than 60 conditions and characteristics, and also includes information on certain drug interactions. The U.S. Selected Practice Recommendations, or SPR, is also aimed at healthcare providers and provides evidence-based recommendations for common contraceptive management questions. It includes information on when to start contraception, how to be reasonably certain a woman is not pregnant, medically indicated exams and tests needed prior to starting contraception, and follow-up and management of problems. The U.S. MEC and SPR are companion documents, and both were adapted from the World Health Organization for the U.S. context. The CDC and WHO work together using an automated system to continuously monitor newly published evidence on relevant contraception topics. Topics with new evidence that was inconsistent with current recommendations were selected for guideline updates at a meeting of subject matter experts in 2014. In addition, new topics were also considered. Over the next year, CDC and outside staff conducted systematic reviews of the evidence for these topics. These reviews were presented and discussed at a second meeting of national experts on family planning and reproductive health in 2015, with subject matter experts present for discussion of each medical condition. The CDC then finalized their recommendations for the 2016 updates. Prior to the development of the WHO and CDC guidelines, most contraceptive guides around the world were based on medical textbooks or on individual clinical practice of the author. They also generally addressed contraceptive use for healthy women, with the result that in many places, including in the U.S., women with medical conditions were denied access to contraceptive methods. CDC and WHO wanted to develop guidelines that were based on the best available evidence that would address misconceptions regarding who can safely use contraception and remove unnecessary medical barriers, thereby improving access and quality of care in family planning. Both of these documents have been endorsed by the American College of Obstetricians and Gynecologists and the North American Society for Pediatric and Adolescent Gynecology. Though some of you are familiar with it, I'll briefly review the medical eligibility criteria. The U.S. MEC contains recommendations regarding a full range of contraceptive methods listed here, and this includes intrauterine devices, including the copper and levonorgestrel IUDs, progestin-only contraceptives, including progestin-only pills, depo-medroxyprogesterone acetate injections, and etonogestrel implants. It includes combined hormonal contraceptives, which are those methods containing both an estrogen and a progestin, and those include combined pills, patches, and rings. Emergency contraceptive pills include levonorgestrel, ulipristal acetate, and combined oral contraceptive pills when used in a certain way. Barrier contraceptive methods include male and female condoms, spermicides, diaphragm with spermicide, and cervical cap. And finally, fertility awareness-based methods include the symptom-based and calendar-based methods. Within the MEC, recommendations for use of contraceptive methods are provided for specific pre-existing medical conditions or individual characteristics. It's important to realize that the recommendations refer to the methods being used for contraception purposes, not for treatment of a medical condition, as this can change the risk-benefit analysis. Within the MEC, each combination of a medical condition with a contraceptive method has a recommendation for use, which is provided as a numeric classification 1 through 4. The numbers reflect an increasing degree of theoretical or proven risk for use of a particular contraceptive method for a woman with a particular condition. Category 1 classifications indicate no restriction for use, while Category 4 classifications represent unacceptable health risks. A number 2 falls in between, and that means that most evidence suggests that it's generally safe for someone with a particular condition to use the method, and that the advantages of using the method generally are going to outweigh the theoretical or proven risks. Whereas a 3 generally means the theoretical or proven risks of the method usually outweigh the benefits of using that method, and other methods should be considered if possible or acceptable to the woman. For some conditions, the numeric classification does not entirely capture the recommendation, and a clarification statement is given. This is an example of the recommendation for smoking and contraceptive use. Down the left side, you can see that smoking is broken into categories by age and level of smoking, and across the top are the various contraceptive methods. For combined hormonal contraceptives, which is abbreviated here as CHC, which include combined oral contraceptive pills, the patch and the ring, You can see that recommendations reflect increasing safety risks with smoking as age and the level of smoking increase. A smoker aged under 35 years can generally use CHCs, which is classified as Category 2. For a smoker 35 years or older who smokes less than 15 cigarettes per day, use of CHCs is usually not recommended unless other methods are not available or acceptable to her, and that's Category 3. And finally, smokers over 35 who smoke 15 or more cigarettes, the use of CHCs poses an unacceptable health risk, which is primarily the risk for myocardial infarction or stroke, and so that's a Category 4 condition. The MEC also identifies medical conditions that may be worsened should pregnancy occur. This is a list of such conditions, which are highlighted throughout the document. For women with these conditions that may make pregnancy an unacceptable health risk, long-acting, highly effective contraceptive methods may be the best choice when pregnancy is not desired. Sole use of barrier and behavior-based methods may not be the most appropriate choice because of their relatively higher typical rates of failure. The 2016 updates to the MEC include 4 new conditions: cystic fibrosis, multiple sclerosis, women using selective serotonin reuptake inhibitors, and women using St. John's wort. It also includes a revised section on emergency contraception, including the addition of ulipristal acetate. The updates also include revisions to existing recommendations for women using hormonal methods with migraine headache, superficial venous disease, taking antiretrovirals, or with known dyslipidemias. For IUD users, there are revisions to recommendations on gestational trophoblastic disease, postpartum and breastfeeding women, women with HIV, and factors related to sexually transmitted diseases. To further demonstrate how the guidance can be used, I'll now go through a few clinical scenarios. So in this first scenario, we have a 28-year-old Gravida 1 Para0 woman who's pregnant and being counseled for postpartum family planning. She's not planning on breastfeeding. What options are available to her postpartum? And our choices are an IUD, progestin-only methods, or combined hormonal methods. Postpartum contraception is important for several reasons. First, it allows for birth spacing and avoiding an unintended pregnancy soon after a delivery. It may be an ideal time to provide contraception while a woman is accessing services and may be motivated to start a contraceptive method. And postpartum contraception is particularly important for adolescents. A recent CDC Morbidity and Mortality weekly report found that 20% of adolescent births are repeat births. So for teens especially, this may be an ideal time to prevent a repeat teen pregnancy. Because postpartum women are at increased risk for venous thromboembolism, or VTE, there is concern that the use of combined hormonal methods, which again include pills, patches, and rings, may further increase her risk of VTE. Therefore, combined methods should not be used immediately postpartum, but they become an acceptable option outside of the immediate postpartum period as VTE risk returns to baseline. As you can see from the recommendations here, the recommendations decrease in restriction depending on the timing from delivery and the woman's other VTE risk factors. All progestin-only methods are Category 1 at any time postpartum, as these methods are not thought to increase VTE risk. The postpartum IUD insertion recommendations include the placement of IUDs in the postpartum period based on timing from delivery. The timing is separated into immediate placement, which is within 10 minutes after placental delivery, delayed placement, which is defined as 10 minutes through 4 weeks postpartum, and interval placement, which is 4 or more weeks from delivery. IUDs can be placed at any time postpartum, although there may be an increased risk of expulsion if placed less than 4 weeks from delivery. Importantly, IUDs should not be placed in women with postpartum sepsis, and you can see that that's Category 4. So returning to our patient, you can see that she can have an IUD placed immediately, so long as this option is available in her hospital, or start a progestin-only method prior to leaving the hospital. If she wants a combined hormonal contraceptive, she will need to wait until 21 or 42 days postpartum, depending on her VTE risk factors. However, she can still be given the method or prescription before she leaves the hospital, so long as she has instruction on when to start it. If she's planning to breastfeed, the recommendations do change slightly, and you can refer to the U.S. MEC for specific recommendations on breastfeeding in the postpartum period. For a second scenario, we'll address the issue of migraines with and without aura. This is a 30-year-old woman with a history of migraine headaches with light sensitivity. However, she does not experience any visual warning signs for a coming headache. She's interested in starting contraception, and we're asked what methods are safe for her to consider, with the options of combined hormonal methods, progestin implant, or an IUD. These are the updated 2016 headache guidelines. Recommendations for headache rely on proper classification of the headache, particularly with regard to auras. This is important because migraine with aura is associated with an increased risk of stroke, while migraine with aura is generally not. According to the International Headache Society classification system, menstrual-associated migraines are considered migraine without aura. These recommendations also assume women have no other risk factors for stroke, such as hypertension, smoking, or age. There's theoretical concern that among women with migraine with aura, the use of CHCs would further increase the risk of stroke, which is why CHCs are Category 4 for those women. But overall, women with migraine can use any method of contraception, with this one exception. So returning to our patient, we know that she does not experience any visual warning signs for a coming headache, which is also how people describe an aura, and so therefore she is eligible to receive any of these methods, so long as she doesn't have other risk factors for stroke. And in that case, progestin-only methods or IUDs are still acceptable. So in summary, the U.S. MEC aims to reduce barriers to contraceptive use, and these evidence-based guidelines demonstrate that most women can safely use most contraceptive methods. Certain conditions are associated with an increased risk for adverse health events in pregnancy, and these women especially need highly effective contraception when they're not desiring pregnancy. I'm now going to review the U.S. SPR. The U.S. Selected Practice Recommendations provide evidence-based recommendations for common contraceptive management questions. It's arranged by contraceptive method and is subdivided into recommendations such as how to start a method, whether backup is needed, how to manage side effects or missed doses, etc. The guidance is provided both within the text document and is summarized in user-friendly charts to guide providers on how to counsel patients for all methods. The U.S. SPR, like the title states, consists of selected recommendations. It is not intended to be a comprehensive textbook. It does not provide rigid guidelines or step-by-step protocols for contraceptive visits, nor does it provide recommendations for well woman care. In 2016, there are two major new recommendations in the SPR. These include recommendations on the use of medication to ease IUD insertion and updated guidance on when to start regular contraception after taking ulipristal for emergency contraception. To demonstrate how the guidance can be used, I'll quickly go through another few scenarios. So in this first scenario, a 24-year-old woman comes to the office desiring to start contraception, and she wants to use birth control pills. So we're asked, when can she start taking them, and what tests are needed before prescribing contraception? There are several barriers to initiating contraception which increase the time a woman is at risk for unintended pregnancy. Some examples of these barriers are the need to fill a prescription, the need to wait for next menses to start the method, or a requirement to come back for a second visit. Quick start is a term used to describe starting a contraceptive method when a woman requests it rather than waiting. The U.S. SPR provides highly accurate criteria that a provider can review with a patient to be reasonably certain that she's not pregnant prior to initiating contraception. If a woman has no signs or symptoms of pregnancy and meets any one of the SPR criteria, a provider can be reasonably certain that she's not pregnant and can quick start her contraceptive method. And again, that means having her started on the same day as the visit as opposed to waiting for her next period or some other day. The U.S. SPR also provides recommendations that address exams and tests needed prior to starting a woman on a method, as unnecessary tests may create barriers to contraceptive initiation. For example, a pelvic exam itself may be a barrier to women getting contraception, especially adolescents, if they're not willing to participate in the exam. Likewise, waiting for test results may be another barrier that delays contraceptive use, which increases a woman's risk of unintended pregnancy. Within the SPR, recommendations for exams and tests are categorized into three classes. Class A are considered essential and mandatory tests before starting a given method. Class B, exams and tests contribute substantially to safe and effective use, but their implementation may be considered depending on the public health or service context. And finally, Class C means that the exam or test does not contribute substantially to the safe and effective use of the method and should not be required prior to starting a method. This is an example of a chart in the SPR of recommendations for exams and tests prior to initiation of contraception. Down the left side, you can see a summary of potential exams and tests, and across the top are the various contraceptive methods. The only Level A recommendations, meaning essential and mandatory, are a blood pressure measurement prior to initiation of CHCs and a bimanual exam and cervical inspection prior to initiating an IUD. This is another summary chart in the SPR that's available in a laminated format for clinics. As you can see, all methods of contraception can be started at any time if the provider is reasonably certain that she's not pregnant. To ensure that she not get pregnant once the method is started, she should use appropriate backup for the recommended time period to prevent a new unintended pregnancy. This chart also includes a quick reference for required exams and tests before starting a method. So returning to our clinical scenario, the recommendation for pills and for all methods is that a woman can start the method at any time, including the same day as the visit, if a provider can be reasonably certain she's not pregnant. If it's been more than 5 days since menstrual bleeding started, she will need to abstain from sex or use additional contraception for the next 7 days after starting her combined pills. Only a blood pressure measurement is essential, but other health maintenance tests can be performed at the visit if indicated for other reasons, but it's important not to delay her contraception initiation for these other tests. In a second scenario here, we have a 26-year-old woman calling the nursing line because she's 30 hours late for reinserting her vaginal ring, and she's wondering what she should do. The SPR includes evidence-based algorithms like this one for later missed pills, delayed application or detachment of the patch, and delayed insertion or reinsertion with combined vaginal rings that providers can use to guide patients based on their individual circumstances. These also come in laminated charts that can be hung in clinics. So using this flowchart, we can see that the patient should insert her ring as soon as possible, and she should keep it in place until her scheduled ring removal day. Since the ring was out for between 24 and 48 hours, she does not need additional contraceptive protection. And finally, emergency contraception is usually not needed in this situation. So I'll briefly summarize a few take-home messages about the SPR. Most women can start methods of contraception at any time, including on the day of the visit, as long as the provider is reasonably certain she's not pregnant. Few, if any, exams or tests are needed before starting contraceptive methods. Women should be advised to return at any time to discuss side effects or other problems, if they want to change the method being used, and when it's time to remove or replace the method. Otherwise, routine follow-up is generally not required. Many options for emergency contraception are available, including the copper IUD and different formulations of pills, and there are many circumstances for which emergency contraception should be considered. Regular contraception should be started after emergency contraception use. And finally, bleeding problems are a major reason for contraceptive discontinuation, and recommendations on anticipatory counseling before starting a method and management of bleeding problems are provided within the SPR. For the last portion of my talk today, I'm going to be talking about how clinics and hospitals can disseminate these guidelines for use in everyday practice. Because CDC does not directly administer family planning services, we rely on our partners to promote guidelines among clinicians. Our partners include provider organizations, professional societies, federal agencies, credentialing organizations, and specialist organizations. We hope you'll consider how you can promote these guidelines within your organization and constituents. Some providers may benefit from updated education on why evidence-based contraception care is important and how CDC guidelines can improve their quality of care. Outreach efforts for clinicians might include emails or e-blasts, newsletters, presentations, educational events, inclusion of the guidelines in protocols or reference to them in clinical protocols, or other focused activities. We're happy to work with you to ease the process of dissemination among your constituents. Another way to promote the guidelines is to make use of our existing provider tools within your institution, and I'll review those now. The first one is the updated CDC Contraception App, which is available for Apple and Android smartphones and tablets. It now includes both the MEC and the SPR in a user-friendly format, with easy navigation between the two sets of guidance. It also easily links to other CDC guidance like the Sexually Transmitted Disease Treatment Guidelines. This updated app is available for download through our website or the Apple Store. And many providers who use smartphones for other clinical references find this to be the easiest way to access the guidelines in everyday practice. And for instance, this is my preferred method of accessing the guidelines when I'm in clinic. The CDC also has printed and laminated summary tables and charts, which can be ordered or printed off of our website. These include color-coded summary charts for the medical eligibility criteria, which you can see in the lower left, and flowcharts with management strategies from the SPR, which include how to be reasonably certain a woman is not pregnant, when to start contraception, how to manage late or missed combined hormonal contraceptive methods, management of an IUD with pelvic inflammatory disease, and management of bleeding irregularities while using contraception. Posting the colorful flowcharts in staff work areas can help to raise awareness and use of the guidelines. Finally, we updated several additional provider tools. Many providers find the MEC pocket wheel pictured here to be useful. This is a wheel that's sort of modeled after a pregnancy dating wheel and can be used to match up medical conditions with contraceptive methods and recommendations quickly in clinic, and it's available for order on our website. There are also several additional educational tools that we provide, like pre-made speaker-ready slides, contraception effectiveness charts that can be reviewed with patients, and CME-approved activities. The CDC contraception webpage, shown here for healthcare providers, is also being updated to include an easy click-through version of the MEC and SPR for providers who prefer to access these resources online, and this will be an improvement from the PDF-only option, which is what the last round of guidance had. So all of this information, as well as tools and aids for contraceptive guidance, can be found on our website. You can also sign up for email alerts to be up to date with any new guidance updates or new tools released from the CDC. So I'll end there and pass back to Michelle.
Great. Thank you so much for presenting, Katie. That was really wonderful. So now I'd like to switch to the Q&A portion of the agenda. So we had a couple of questions, and actually, Katie, you addressed one of them in your presentation about the wheels. And then the second question, I don't know if Valerie Coleman wants to unmute herself to talk about a question a little bit, but she wanted to review breastfeeding patients and informed consent about DEPO.
Do you want to ask the question, or yeah?
Well, let's see here. So Valerie, if you have not been able to unmute yourself, let's give her a moment to press *6 to try and unmute herself to ask the question. But Katie, if you wouldn't mind, it seems like her request is for you to please review breastfeeding patients and any information you might have or thoughts on informed consent about DEPO.
Sure. So our recommendations for breastfeeding vary by method. So for implants, DEPO, and Progestin-Only pills at less than 21 days postpartum, they're all Category 2, whereas combined hormonal contraceptives are still Category 4 for the VTE risk reason that we discussed earlier. And those change as you get further out. So with regards to DEPO specifically, we have an informed consent. So of course we support that breastfeeding is an important benefit for moms and infants, and we certainly recommend breastfeeding, especially early on and continuing through 6 months of life. With regards to the evidence for progestin-only methods with breastfeeding, 2 small randomized trials found no adverse impact of breastfeeding with the initiation of an etonogestrel implant within 48 hours postpartum. And then other studies found that initiating progestin-only pills, injectables, and implants at less than 6 weeks postpartum compared with non-hormonal use had no detrimental effect on breastfeeding outcomes or infant health, growth, or development within the first year postpartum. However, these are limited studies. They're limited in quality, and they don't necessarily have standard definitions of breastfeeding or their outcome measures, and they didn't include premature or ill infants. And so certain women who might be at risk for breastfeeding difficulties, such as if they've had previous breastfeeding difficulties, other medical conditions, perinatal complications, or preterm moms of preterm infants, that discussion about contraception should be individualized, always talking about risks and benefits and alternatives. But again, the evidence is not entirely concerning. But it is lacking in those specific situations.
Great. Thank you so much for answering that question. I just want to jump in here. This is Andrea. There's a question in the chat pod about using this webinar for CEU credits. I just want to clarify, AMCHP does not register this webinar for CEU credits. We typically, for these guidelines and updates webinars for our Women's Health Info series, we typically do not register them for CEU credits, so this webinar can't be used for that at this time. We're always happy to hear from participants and others on how can we best make these webinars useful and assist you and assist your teams and staff in participating in them and making time for them. So thank you so much, Eleanor, for joining us for this webinar, but unfortunately this webinar is not available for CEU credits.
At some point in the next month or two, though, we do anticipate similar slide sets to be on the CDC website, which you can use for CME or CEU credits. So that is an option if you want to review this again.
So what questions might anyone have or feedback that you'd like to share with the presenters? As a reminder, you can enter your question in the chat box, or you can press *6 to unmute your line and ask your question.
Hello, can I ask a question?
Absolutely, go ahead.
Hi, this is Maria Rabowski-Herrera. I'm a public health nurse at a local health department. I do the nurse home visiting, so I speak with a lot of women about birth control. One of the biggest barriers that I'm still seeing is there is a huge fear of difficulty getting pregnant after stopping birth control. And sometimes, you know, even if you can assure them, oh, it just might take a couple months for your cycle to get back to normal, there's still this big worry about future infertility and, oh, what if it takes me 2 or 3 years to get pregnant, and that's not good enough. Any words of advice on how to address